Scott County, providing safe, healthy, and livable communities.
Would you just explain, I know it came up last week, the difference in the beds each at the crisis center, so what the difference is, that it serves kind of two functions there was kind of our understanding of that?
Of the Earth facility. So we have the 90-day stay there, and then also the crisis beds as well.
Okay. Just a housekeeping item. The mic is backwards. Red does not mean danger. The mic is hot. Red means so much. So when it's green, they can hear you. We'll get used to it. We'll get through it. Thank you, Barbara, for this presentation, kind of encapsulating the wide-ranging. We went all over the map 2 weeks ago. This big presentation. We're sure what we needed to do, but the shower and must in the state statute certainly focuses on. Certainly makes me wonder what the world we were up to in St. Paul when we were saying those things, because I noticed it says, and it's just an editorial comment, we always use all resources to accomplish these missions. Does that mean up to 100% of the tax base? Does that mean drop snow plowing in order to run a crisis mental health center? I don't know what that means. I don't think they do what I think either, but they wrote it. But well-intentioned people full of enthusiasm and trying to do the right thing wrote a bill that I'm sure lawyers would have a field day trying to sort out. That's the end of my editorial comment. Thank you. Absent any other comments or questions for Barb, let's turn to the panel. I think, Chris, you usually have these things up for us, don't you?
Thank you, Mr. Christopher. Good morning, Mr. Chairman. It was nice to as everyone knows, we're here to talk about school commitment, and as Lindsay referred to, really the post-pandemic deep and our mental health system. And I was thinking that it is important to remember that the data that really reflects the experience, and these are largely people who are a lot of distress and a lot of pain, people who are ill and who need help and often talk a little bit. We are also going to talk a little bit about their families and people that worry about them and sometimes their health. And so those are some of the challenges that all of folks are facing today. We're very fortunate to have really critical expertise on our panel, and we ask those folks to really help in just a minute. But first, if the listeners can consider these two
Hi, Chris Levin, from Community Services.
Dan Lyons, Office of Management.
Thank you. Thanks for being here. And then I'm just going to go down the list as it appears on the documentation. So,
Good morning, Mr. Chair, Commissioners.
I believe you were with us remotely. Lori, are you are mute? If you are able to, yes. Okay. She may be one. Maybe Mary, you should have
My name is Amber Barnes. I am the lead adult mental health case manager for Scott County.
Terry Raditz, are you available for us?
Hi, I'm Terry Raditz. I'm the director of the Mental Health Center in Scott County. I am having some audio problems, so hopefully you can hear me, and I will listen hard.
Terry, we can hear you, but your voice is soft, so as best as you can speak up, that would help us. Thank you. Thank you for hearing me. Is Tanya also there? All right. Tamara, do you introduce yourself, please?
This is Tamara Sievertson from St. Francis Regional Medical Center, like Dr. Raditz, I'm having a lot of trouble hearing what's happening in the room, but we'll listen super hard, and really excited to listen to the presentation as well.
Thank you very much for being with us today. Amanda.
I'm Amanda Watkins. I'm part of the adult mental health unit. Hi, Heidi Schultz, adult mental health case manager and also pre-admission screener.
All right, thanks to all of you for being here today. Jamie, would you get us started?
Yeah, so first question will be from page 10. And it's the average number of days from referral until an assessment. So I'm seeing that, and I know that probably fluctuates with the number of referrals you get throughout the course of the year. As we talk about assessment, what does it look like in terms of as soon as someone's assessed, they go right into services and treatment, or what's that time that they're starting to receive services?
I can take that one. Can add in. But this picture shows from the day that someone contacts us, from the day that they call to the day that they get an assessment, which is typically by our wonderful intake workers too. There are also a number of pieces that collectively add to this puzzle. So from the day that someone calls to the day that they sort of start getting into the detail with the case manager, this is a portion of that, but it can actually be upwards of 90 days that someone's waiting. And that can be for a multitude of reasons, but this is not the whole picture. Unfortunately, people don't have access to that service immediately when it's requested. I guess I'll just add, part of the assessment process is getting a diagnostic assessment completed. And I think that's probably where we're waiting the longest. Is just getting individuals into clinics, whether it's mental health center or other outside providers, to get a diagnostic assessment completed to make sure that they fit, the requirements of case management.
Part of that time while they're in assessment and have called in saying, I need services, we're waiting for a diagnostic assessment, which shows yes, they qualify for our services or no, they do not. Sue, who is our only assessor right now, she does main case management and care coordination, where if there's more to be done in that moment, all the referrals that need to be made, it's not like we're just not doing anything. They made a call, we're not doing anything until we get that diagnostic. She does a lot of work during that time to get things started, to get it ready for the case manager to pick up and keep forward.
I think one of the themes that we'll hear sort of throughout this presentation is sort of back to Barb's point of enough, and is there enough at various points in the system? This is huge. One of the things that I think I see when I look at this data is, do we have enough of that outreach and engagement? Are people sort of calling and saying, yes, I'm so excited to be there and I will be there tomorrow to start the work? Sometimes no. Sometimes we need someone to help encourage them, support them, make it a little bit easier, make it community. I think these guys have made some shifts, taking advantage of the virtual environment of COVID-19 to eliminate some of those barriers. The other piece is, I think, coordination. Do we have enough of that coordination so that when someone contacts our adult mental health case management team, they've got that in-between support? And if they need to have someone come out to their home for crisis services, or they need to be hospitalized in the meantime, do we have enough of that coordination that pulls the full picture together that can support that person?
Okay, just following up, as you were talking about some of the outside case management that your assessor does, children's mental health and health presumptive eligibility until a diagnostic was like, there's such thing. I mean, do we know there's a diagnosis? We just need to know whether it is different, is affected by bipolar, major depression, or like personality. And that the therapist needs to actually that diagnostic assessment that they're seriously serious emphasis on like that. In children's mental health, it's definitely so it's similar. But you don't have the ability to launch case scans. You can do some of that through the intake staff, but because
all these pieces like that.
Kind of follow up to that. And probably the slide is page 9 on the And someone may have explained on this a little bit more to me because I've seen it very data. When I look at this, is for, and then we look at after treatment and providing with the improvement. How does that delay in treatment impact scores? Will you see deterioration over time because of lack of treatment? And then what is the impact on improving those scores because of that? Question, thanks.
The lowest is a tool that we use every 6 months. It also is used if someone needs a higher level of care, like in a facility, they have to meet a certain level. So we use it just as a measure. It's not necessarily something that they do every day. It does show over time. Over time, if we plug in services, has their level of safety, everything that's going to show other negative or comorbidity that has to be over clinical use issues. That's kind of what that literature score helps us look at is has some of that lessened, has some of that stress lessened. There's different behaviors within that test that show what that level will be.
Also, what I see looking at this slide is this representative of everything that we're seeing in pre-petition training? So, as was mentioned, pre-petition training is the key. This is where individuals actually have the right to the way and enforce it rather than international engagement. So, and these guys can speak to this. Are we seeing in their pre-petition trainings and commitments that we're serving in good hands? We're getting these locus scores done. Because if I had to bet, I would guess that those folks aren't represented here because they're not already engaged in services or not to the extent that would potentially help them. So we're away from this process.
Right. Yeah, I think the majority of the pre-petition screens we're getting in, they're not looped in with services, which essentially is why the pre-petition came in because it's in the hospital, severely mentally ill, very symptomatic, please development, I mean, you name it. That's kind of what triggers our commitment. So if they were already involved with case management, continuous thing, it would be reflected in the locus score.
We do a locus for people who are committed once they're committed in case management. So hopefully we do see a decrease, but sometimes again, they are so sick, they haven't been connected. It's going to take some time to get them back down.
Do you track that so you could say, as kind of a subset to this one, the number of people whose first contact was through a pre-petition or commitment and what those locus scores are and kind of juxtapose that against people who are brought in due to a referral and be able to regulate that to look at that referral population versus pre-petition commitment population?
We can track referral sources and the outcomes of those referrals. We would love, I think, to have more of that data detail that tells more of that story. The majority of the data these guys are collecting that's included here in the presentation is a manual count. So I think that would be excellent to be able to see. I think unfortunately what we notice in our intake data is that far too many people who are referred to services do not end up receiving them. And Lori Weller is not here today, but I will use one of her examples that she always provides, which I think is so funny, but applies. She says, if my neighbor or my husband or a family member called and gave me a referral to Weight Watchers, and I was really not ready to make any major changes that day, I'm probably not going to be able to follow through. But if you have people who are seeking services themselves, who are interested, who are engaged, and trying to make a connection to that person, we see that makes all the difference. So unfortunately, when we get to this point of pre-petition screening or commitment, that relationship is forced. So we think that there are plenty of opportunities in prevention before someone gets to that point. And I think there can certainly see that in the field. But the idea is let's not lose any opportunity to connect. So whether we're connecting with someone in jail or potentially with a future correspondence with law enforcement, or someone shows up at our door, or someone has a referral that's made, some of those things I think are in place. I think
too, the change that we see when we're working with folks, whether it be in case management or commitment, that progression is really slow. You know, this illness impacts every single area of their life. So sometimes at the end of a 6-month commitment, if you've established good rapport with somebody and you can keep them working voluntarily, that's a win. It doesn't necessarily change that locus significantly, but it's that engagement, and we keep working that process. So our progress is seen very slowly.
So before we leave the locus first, so for people who don't work in your world, what does it mean to your team that those percentages of people that show improvement, what does that mean for your team?
I think it goes with what Heidi just said. Like the locus is a good tool to see where people are at, and then every 6 months as we're working with them, is that getting better or worse? But it takes a long time, and these are SPMI clients. They're severely and persistently mentally ill, and this is a lifelong thing. Although we can get in and get services going and psychiatry, therapy, or whatever sort of in-home or community supports, there's still that illness is not going away. It may be less intense, and you know, we can decrease hospitalizations potentially by connecting them with services. But that's why the locus sometimes is a hard measure to use, because it doesn't necessarily in 6 months we're going to go from 5 to 1. So I mean, it's good to see that there's some improvement, but again, these illnesses are lifelong, and there's challenges. We could see improvement in 6 months, or it could be a year or 5 years. So it just takes time.
And also really speaks to we as a county entity, or even as a management entity, are in control of everything that's happening in that environment. So this, I think, is a good indicator for case managers to say, you know, collectively, how are we doing? But it's also a key performance measure of our community. So what are the other factors that are contributing? And we saw with COVID-19 some increasing concerns with support networks. People didn't have access to the same supports that they did before, whether that was a public and private provider or their informal supports with family, friends, neighbors. Some of that will away. So that is a concern here. We saw a major impact in workforce shortages across the board, and that was not specific to Scott County or even the state of Minnesota, but we saw residential programs close down. We saw people who had individuals coming to their home providing independent living skills no longer doing that because they can't manage the staff. So again, back to Barb's point of what is enough. We saw sort of our baseline change over COVID-19 in the last 2 years in the decrease of resources to sort of get to that collective amount.
That shows the average hours spent in 2017 to 2021. The number of screenings have increased, but the hours
I think the higher volume is one. Unfortunately, we've had more cases come in through the door, and I think these guys speak to the higher level of needs that people are presenting with. But they can speak wholeheartedly to what it means to have less time.
There's a few other factors too. I mean, just even mileage, getting to and from some of these hospitals, you know, that takes an extensive amount of time. We're also getting these with a lot less notice. Typically, you have somebody that is 12 old. Ideally, that's when we get that request. Sometimes we don't get it until there's 5 hours left. You do the best you can in those 5 hours, but that is a big contributor to why you see some of these schools going down. Police calls 72-hour holds, different policies at the hospital, that we can't control. We just have to get in there and jump. But just run that a little bit more too. We used to, as part of the screening, when we get that call in from the hospital, we have someone on 72-hour hold. We used to drive to that hospital. It was very rare that we would do that by phone. And so we'd be all over the metro, or and Cato. You know, sometimes if it was a further out state, up north, very far north, we could do a phone call. That makes a little more sense. So that has been a decrease. And again, sometimes I've gotten one at 3:45 p.m. and it's due to the county attorney's office by 9 a.m. next morning.
going to the time that we have that's we have a large chunk of time to get that done.
And absolutely.
So it does, but we do what we have to do and try to work with folks. With the phone calls that I had to with COVID, there was a little bit of change for the willingness to do that. In the past, we've been a little bit more restrictive of moving. Jerry didn't want to see those sorts of things, so I think as those changed, it did open some opportunities there. But to their point, yes, there's also been a statutory change where we're seeing more being referred from the hospital, but perhaps and then also they have to get them to us with enough time to appreciate their part. So that just brings them even
With spending less time on these individuals, does that impact the quality of the assessment where you have to, I'm not trying to say that doing a good job, but being able to spend enough time to say, yes, we do support them having commitment? And do you feel like that's a harder job to do and feel confident in your decision?
I can take that one. You know, I think absolutely it's going to impact that overall picture, because one of the things that I've seen, and I've been with our county almost 30 years, is that we do an incredible job of really doing an all-encompassing look at what's going on. It's not regurgitating the hospital records or what we call exhibit A, which is kind of the behavioral evidence that leads to a commitment. So we can't be as thorough, but we still have to meet that statute. We have to meet that standard. So you look as much as you can. We're kind of seasoned to know how to pick and choose information. And then our team to staff is absolutely critical. So those base elements are always there. I wish we could be more comprehensive sometimes, we can't be. But that base element is always there.
Yeah, just to add to what you said, I did a pre-petition screening in last week, and it was like a 69-page medical record that I had to just skim through. A lot of it is like lab reports that maybe don't pertain to me. You kind of know the areas to kind of zoom to, nursing notes or the psychologist assessment, things like that. So you get kind of used to being able to navigate through the paperwork things and being able to pull information.
And part of these screenings is also requesting local police records. A lot of times these people have clients that are brought to the hospital via EMS or a police contact prior to going in. And thankfully, the police department and the sheriff's office have been pretty quick to get those to us when we send records requests. So that does help us work forward too, and just looking through those police reports once we get them quickly and the hospital records, and it's helping us kind of hone in ourselves a little bit, and we've done it for a while.
But really those partnerships, I think, are key to the success. We are so lucky in Scott County that we have an excellent relationship.
Really good people, like you're saying, knowing where to hone in on. One of the things that they do is contact family members that give more of a picture of the history of what's been going on and some of the things that they've experienced. So being able to ask those questions to present that in their report. Sometimes when they haven't had a lot of information in the police reports or something like that, that can make a big difference for where they're going moving forward and what's appropriate. If they can offer services and perhaps screen it out, I should say screen it out, that's the other thing, but not actually move forward with pre-petition screening and support after they've already gotten.
Let's talk a little bit about that. I did on page 12. So as you talk about kind of holding those assessments and the experience of your staff, I might ask somebody to reference through this slide a little bit, but the heart of my question is, if I'm reading this right, in 2021, 49 cases were supported by the court. Is that correct? And then 20 of those were not supported. And I'm wondering what you learned from those 20 that aren't supported, because there's a lot of research that goes into those as well, right?
like the same work goes into that. And so like, what do you know about those cases that are not supported that like impact how you hone those skills and how you work with families?
That piece, I just want to clarify that support versus non-support is our piece of the process, before it gets to court. So the judge may still decide,
Okay.
which is rare. If we decide to support it, it's rare that the judge wouldn't also uphold some version of the commitment. But the non-supports typically mean that we've done the same work. We've reviewed the records, we've interviewed the client, we've interviewed family members, we've gathered whatever other records we can and screened it with our team. And either the person has started to be more agreeable in the hospital, started to see a decrease in symptoms, or maybe they have been connected to services and are willing to re-engage with those. That, and we feel like maybe the dangerousness that was originally presented is maybe less so than initially thought. And so with those non-supports, we see, okay, we can re-engage with them. And typically those people that are not supported then are voluntarily working with developmental health case management after that, rather than a commitment of being forced for them to work with us through case management. Those non-supports still typically come through case management.
So I guess what I'm asking, like, is there a way, knowing how much research goes into this, does your team have opportunity to look at those non-supports and think, maybe we could screen this differently, or maybe I could change something about our assessment?
Well, the non-supports basically mean that person just didn't meet that standard. So that same process has to happen. You don't know that I could answer that question any differently other than it just means they have not met that threshold. And we always have to look at the least restrictive alternative. And that might be allow them to be voluntary, even though our gut's saying they're probably not going to make it. The evidence says they got to give this a shot. You know, that's what we're mandated to do. So,
I'm not sure.
What after that though is that if it's not being supported for commitment, it's not relevant here. Which typically means we can find an opportunity to engage with this person and to provide a service that doesn't get us here. So this is after that person's met with these guys, we've looked at all their documentation and they've been engaged, right? Like some of the missing pieces from our community is that opportunity. We don't have an entity that we identify a need here, that person can go over and really try to see that engage in services. And so to me, that's a what if. What if before this petition came into the county, what if they would have been engaged through any help with law enforcement or with our jail, or if somebody had called in or they themselves have called in? What if we would have just approached them sooner?
I have a question on page 17. If you look at this slide, it says that in 2021, law enforcement made referrals to the mobile rights team. Out of that, 54 assessments were completed. So what was happening at those referrals? And maybe one or two opportunities that we could explore those people that are in the assessment process.
So the reality is not much. Law enforcement can make a referral to our crisis team for a crisis assessment, and they will refer them if it's appropriate. But this is a voluntary service, so someone has to be interested and willing to engage with our local mental health crisis team. If they don't want to do that or they don't meet that criteria, there really isn't another entity. You know, law enforcement might provide them with some referrals, but they could see them again, or they could also see this person.
And I think that number will continue to climb due to tremendous amount of state, both all law enforcement interactions. So law enforcement has this best interest to refer as much as we can to make sure we're meeting our facilities. But we have to do that. So one thing we've created in the last few years too is the entire representing system is formed. So an officer has a kind of call or a call. So let's go to 911 was a piece of instantly sending an email to Canada. So the little person's domain matters, phone number, the first officer. Here's what we just dealt with. Here you go. You know, it's referral. So it might not be an actionable referral for them, but it's giving them a heads up what's going on. Also knowing that they may also be dealing with that family, different piece, so it's trying to just build more data points, but referrals are increased quite a bit. We refer straight from law enforcement or
So do you find like the people that don't volunteer for this process, you're seeing them multiple?
Yes, I think I can see the board, that's the frustration. One of our here as well, is can't make some of these changes. But you know, so then you still go to the house. But you can't do that, or you can't do it.
And that's the piece too with, going to the deep end and the commitment stuff. Unless they're in danger to themselves, yeah. So you can have someone in the community who's causing a lot of issues, but they're not progressing to that level where it's slide over and force anything on them. But that piece of tracking that is also important for having that full picture when they do finally come in. Because if none of that if it kind of existed, there's nothing for them to track down to kind of justify that one time just being in the hospital, it may not look that bad, but when they have those other pieces, it's part of the picture that could help push it over.
Look, I mean, 400 feet for those medium distance, amount of those for step 100. What is the chance of this data? We talked a lot about our.
The assumption I would make is the word is these types of calls, it's not traffic stop. It's not somebody has to do hours in a business, it's usually more at somebody's house or, behavior in the community. So I would guess good chunk of it,
This is a subset from our mobile health crisis. And the vast majority of those services are provided.
References kind of the times that we were in and some of the things social that contribute to mental health crisis. And I wonder if some of you could talk about county has invested quite a lot in mental health in the last year, right? And we still see lots of people in crisis. And I wonder if you can talk about and Danielle, I think you were referenced earlier, outreach was one of those missing components. I wonder if you could talk about what, given the investment that's already been made, like what else can we do? Like what else is missing? And maybe it's outreach, maybe.
Yeah, I think we've had a great amount of success in Scott County, and I was feeling kind of bad because this presentation sort of is the doom and gloom, and it is the result of some unfortunate circumstances. But Scott County has invested in mental health in the development of our intensive residential treatment services and our emergency crisis and field operates. That is a monumental thing that we have provided our residents that no longer have to travel sometimes out of state to get that service. So these guys folks that impact us for that driving back and forth, serving people in that local community, in their local community is so important. So that has been a success. We've worked with our other community nonprofit providers, for example, in the development of mobile crisis and the behavioral health home services that Guild Incorporated is provided. We also partnered with a mental health and homelessness outreach worker, which is it's a small subset, it's true, but can go out and engage people who are homeless and experiencing mental health. So those are some incredible successes that we have had. I think where we have some opportunity potentially is again taking advantage of some of those opportunities to engage people, whether or not they're in general, and finding a way that we can coordinate all of these things. Unfortunately, it's not easy for somebody who is receiving one service to give the other services a full picture of what's happening. So if there was an opportunity, I would say it's that coordination.
What would that look like in your life?
I think we would need to develop what that looks like. I think it looks different in all communities. Some communities have seen that developed in a physical site, a hub where they co-locate services so that people can walk across the hall. Some have structured resources, as Bart was talking about our potential designation that the county is exploring around behavioral CCB there's data collection that goes into various points of the service that we'll be able to look at. So I think that list of various communities, and I don't know that we have the exact answer of what works for staff, but I think we're doing the research that we need to.
One of the questions I had, looking at the mental health and crisis performance assessment for page 15. Kind of runs together. Does the county track the outcomes of those to say, okay, of these crisis appointments that result in assessment, what are the outcomes of those that we track and look at what percentages yes going into X, Y, or Z service or what services will be.
I'm gonna hope that Dr. Raditz is online and can speak to that, but maybe we'll choose, hopefully your audio connected.
Okay, I think I heard the question. I'm listening closely. I'm sure my answer would have been much more insightful and brilliant if I could hear well, but I think what I heard was, the question is, do we track the outcomes of our crisis assessments? And the answer is yes, we track outcomes of all of our services, as long as we have the ability to have contact with the clients so that we can do the functional assessments. So many of our assessments we continue to see. We set up our crisis assessments so that the person doesn't have to tell their story twice, so that they can, if possible, they can continue with the same provider after their crisis. And we do ongoing assessment of functioning with standardized measures throughout those services. There are some folks, though, that we would see, for instance, at the jail, and they would be discharged from the jail, and they would not necessarily come in for services. So those we wouldn't track. I hope I heard the question right.
You did, and I forgot for the instructions to speak up and at the microphone, so my apologies.
I'll add on to that. You can also see sort of the crisis assessments that are provided by our staff in the mental health center are captured on page 15. And if you look at page 16, those will be our mental health crisis assessments provided by our mobile team, which is a smaller subset of that data. But because of the way that our grant funding works, we're able to track a little bit of what the result is. So we can't necessarily see the result of how many referrals were followed up and the full story of that, but we can see what happened at the end of the assessment. Were they sent to the hospital? Did they have to go to another intensive treatment facility? Other pieces, which I think that's another thing Scott County can celebrate, because years ago with our mobile team, the result of many of those assessments was a hospitalization. They were admitted to the That's no longer happening. We have a much smaller percentage of people who are going to the hospital or having institutional stay following an assessment. So that is something to be celebrated. Another thing with that is these are face-to-face contacts. We had previously seen a lot of those contacts happen in the hospital at the ER. So someone had already been in the hospital when these teams were going out. We are now seeing a far greater number of people being seen in the community, in their homes, which tends to, I think, be a much more appropriate and
On page 18, there's that crisis, the Kansas data and mental health center data for assessments and beyond. And first, I think it's important to recognize significant increase in the volume of overtime jail studies. We've all been talking a lot about the prevalence of mental health issues in jail. The vast majority of those are by the county mental health center. Can you just talk about how those two systems work? Are you guys sort of alignment to do that, or how does that work to the benefit of the people in the
Yeah, so it gives us that 24/7 coverage. So mental health center is our system that is our nursing staff, does these referrals. Crisis, again, during those hours. Or there needs more diagnosis, stabilization, for the mental center. appointment-based. Can I ask Luke a question? Luke, when you talk about somebody coming and stabilizing the situation, are we talking about physical restraint, calm voice? Drugs,
situation where we have so them getting arrested, when you run somebody who for we can't so yes, bring in. We talk with them. Just listen to that or some of these folks community or what is already being and some of these that have also go to the hospital. Last year or two, spent 10 days in the hospital, was in very serious charges. So we know from the police department to go to the hospital and have them get. Function, or beyond our community. So if it's in the hospital, it could include restraint and sedation and something like that. Typically, that's how it works. Okay. Trying to get an idea of what this looks like.
I'm really sorry, I couldn't hear any questions or comments related to this slide, and I feel like I should be giving you the answers that to your questions, but.
Difficult to hear, yes. I had a question for the process of what it looks like for the sheriff. I don't know that you could have answered the question if you could even hear me now. So I'm sorry, you guys were in a process and I kind of interrupted you.
The other piece just to follow on that price is on the data unearned on page 19. So there's a breakdown of intensive treatment and all the prices. And how do people access those prices? Is it right that there's not is there a diversion from the jail for people who are in mental health crisis? Or how do people access those prices?
So crisis would be typically 10 days or less, and the ERT spend would be about 9 days. So it's not necessarily an easy like drop off zone where someone can present with a need and there's an intake process. They have to determine if that person qualifies. So some of that stuff might get worked out, but we have not, I think, been able to sort of have an alternative. You get booked into the jail or you won't get. It's unfortunately not that easy.
So it's jail or hospital. Those are the two choices that exist right now.
But by definition,
Yes. Well, crisis spend is a step below the hospital. It's, let's try this. They're not, maybe they're actively, but they don't need hospitalization. They don't need immediate medication and a secure facility. So these crisis beds are available. You call PMS, they help facilitate that, or the person themselves calls and says, I'm having a hard time. I'm really depressed. I'm really anxious. I'm not sleeping. And then just need some structure and not the hospital, not a secure setting. And so if they meet that criteria that they're in crisis, this isn't because they're homeless, this isn't because they don't have the money to go stay in a hotel for the night, or have the money to go wherever. This is a mental health crisis that qualifies for crisis stabilization bed. And they can sometimes be there for one day. They just need a minute to go talk to one of the mental health professionals there, stay there for a night, get a plan, and then they go back home or whatever. Sometimes they end up in the hospital too, if there's symptoms that are manageable. So that crisis bed is kind of an interim for let's see if we can avoid the hospital or in our state. That is another, that's a barrier with, earth placement. You have to either have medical assistance or it's private pay, and typically, if you don't have medical assistance, then that's what we should.
I think the other thing to highlight is that if they are engaged in services, their case manager, they could reach out to and say, I'm having a hard time to have a facility or a home stay. If they're not engaged in services, then the likelihood is higher that they'll potentially present at the hospital or to law enforcement or to jail. So I think that's a preventative measure that, yes, sometimes still has its barriers, but when you have those connection points to the crisis service, or they present to the mental center or to these guys, they can help bridge that.
So if I follow, then up to 90 days is the intensive. We have those other 8 beds or whatever it is for the crisis. They're under 10 usually. Is that what you said?
Yeah, correct. And that facility has been extremely creative. We work with field ongoing to see what it is that our community needs. They have what they refer to as swing beds. So those beds can shift if we have more people who are presenting in a crisis or more people who are presenting in need of that longer stay. There's some flexibility there where we can create that movement.
All right, I think what I'll do now is pause and just give our audience an opportunity to ask any questions that they may have.
It just strikes me. So those of you that have been around for a long time, Danielle in particular, too. Back in 2014, one of our board strategies was really around how do we keep folks with mental illness out of our jail. And as I look at that data, it's pretty concerning to me, and we are not doing a very good job at that. We did a lot of good things through that board strategy back in 2014. Our change with local crisis, the guild, a number of different things. But what do you guys, you experts out there, see? What is our biggest gap right now? I think there's something, and I know actually, I remember from my conversations back then, I got there's no magic bullet in this continuum. But what do you guys see as our biggest gap?
The thing on the top of my mind, and Aaron can speak to this as well, and actually, but some of what's changed in the last year or so is the use of force laws. And so when we do ask police to go respond to a crisis in a community, things have changed. They used to be able to take our people, even if they weren't as willing to go, and bring them to the hospital. And it's just trickier and trickier to do that. There's a higher level for them, whether they need a court order from us to say yes, go pick them up, or the person has physically done something to them and not go allow them to bring them in. So a lot of times, I mean, you've seen this in a couple of recent cases that have come to us. There's 40 police contacts in anything. But it was never conceptual to be able to bring that person in until it was. And so that's definitely been more and more of a barrier because we can't rely on police as much to help us get people to the hospital. So then I think that's laying them in jail more often because they're doing something more criminal because we can't get them in. And it's kind of our hands too because we can't go pick people up and bring them in either. You know, when it gets to that point of a crisis, we really need the police and EMS, their support to get people to the hospital. And I think sometimes that's probably landing them in jail.
Well, use of the force law changed last year. So across the state, but basically it falls into force because mental ill, encouragement is not force for them, but there's some encouragement. Some levels of government where it's like, okay, we'll go into less calls or engage less so we don't get into that trouble. I have a local crisis going on. So I think we still have for agencies. And then I think I don't know the fit, but also personally with their numbers, it's a real severe trend coming to us for a long time. Have this piece as well, so that's where I see our numbers grow. So instead of somebody coming in for a week and staying an hour and maybe has a mental health crisis, it's going to be somebody that's coming in for a very long time. So, that's where some of those are. I don't know if the numbers play out, but I see some
And to Luke's point, that patchwork, I think it is trying to weave that patchwork together. How do we coordinate our provider network so that we are collectively responding instead of doing our individual roles, but also to take advantage of those opportunities to engage someone, whether it's just like the 7 minutes with law enforcement, if it's in the jail, if it's just a call that comes in, being able to go out and hopefully engage someone before they get to that level.
So other jurisdictions have looked at the dual response, mental health and law enforcement. Does that help that use of force issue or?
I think it does help, but I don't want to speak to sports issues. We haven't changed for us last year, so I can't. The questions don't know how to interpret it, but the co-responder is definitely beneficial. That is how we're showing not only law enforcement, we're bringing mental health professionals as well to engage the person, help them, versus trying to say somebody saying, oh, something went south, why did that happen? Here you're showing we're bringing extra resources to try to let professionals engaged, with that.
I think it's also important to just mention the individuals that have their own chemical dependency. There is definitely a severe lack of aspects. Last year, and it's really we use pneumo detox, and pneumo detox can only take a maximum of 3 people who are on commitment, and that's just not Scott County. It's all the individuals or counties that use pneumo. So we have clients who go to the detox, go to the ER, sit there until they're sober, and then they get let go. So that's, that's an important part too, as far as people going to jail. It's you're not going to find the police going to drive somebody way down to Rochester for a detox. All those things play a part.
I think also, I don't, it's not a coincidence that our commitment numbers are going up and then we're seeing something happening in the jail at the same time. Because when you're working with individuals who are rising to that level of commitment, there are people who are moving closer and closer to dangerousness. And what does that look like in a community? Your interventions are either going to be civil commitment or you're going to start acting out in a different way because you are meeting a threshold of dangerousness. So I don't think that those numbers are rising together. It's just the reality of the environment we are in with people who are mentally ill in a pandemic and what that looks like for those people, because a lot of their services aren't available to them and aren't, we just can't respond in the way that we have. I'm not surprised by those things.
This 2014 strat plan, because we had the mental health center, we had the herbs, we had the crossover youth, but we also had a reentry person that was supposed to be at the jail to help. And I was curious, I don't know that I've heard an update from anybody on that, but they were supposed to meet with people leaving and help make sure they had their appointments and things set up. Have we seen some benefits from that position from, I don't know, Luke, if you'd be the one, or somebody, Danielle, where we're seeing improvements from that, because they were supposed to meet with these folks when they were leaving and help set up the appointments. That was part of that strategy as well. I was just curious if we've seen some benefits from that position.
I think probably Molly from Directions is best to answer that question, but I can just share sort of what I've heard. We have had a staff person that was previously, she still is, Katie Pearson, a holy community care case manager. And she spent the better part of the last 2 years doing 1,000 assessments with our jail inmates, which not surprisingly captured around chemical mental health. But also had provided sort of some short-term support. I think what she has seen in her experience is that the volume is much greater than the 0.5 reentry, and also some of the needs that we're seeing in the jail might not be able to be met by that resource because of the criteria. So she could probably speak much better to that. I will say that again, that was another added resource that has benefited our community. But again, we come back to that
Katie can also work with individuals who are not Scott residents. I'm not sure if reentry that position can work with other county, only Scott County residents that are involved.
Thanks, Ian.
Any audience questions before we return to the board?
Just a quick follow-up to the very helpful conversation you just been having. Is the reason for the change related to increase in numbers of people that are living here? Is that other factors that you're seeing to COVID, to other kind of public issues, social issues? What are the variety of reasons why we're looking at increasing numbers? What is that all about?
We don't necessarily know all of that. I think the numbers that we are seeing as far as the percentage of increase far exceeds the increase in our population. When you look at a 42% increase in pre-petition screenings and commitments, we have not had a 42% increase in population. So that tells us that something else is going on. And these guys have spoken very well to some of those impacts that we've seen with the COVID-19 environment, but just also in general, I think we're seeing.
I could probably speak to that for like an entire day. It's so complicated. I mean, we've had changes to medical assistance, ability to pay for medications, ability to get medications to people. We've had just a change in population with the pandemic, the isolation, increase of substance use. We're seeing different presentations of kind of older onset psychosis. That's kind of been a trend. We're seeing more interaction with law enforcement. It's kind of this picture just kind of culminating. I don't see that coming to an end anytime soon. The ability for us to be able to get out and engage with folks, the distance sometimes that's involved, and then I kind of bring that back to isolation. There's such big components.
As far as that was interesting and thoughtful and yeah. I have a hunch we could probably sit here all week and still plot deeper and deeper. And the 5 of us, except for maybe one of us. Colleagues, I'm going to call on Commissioner Brecky first. She has about 4 pages of questions. She will ask some of the questions before answering. So, hold on here for 2 minutes right now.
Yes, thank you for that. Thank you. No, it is serious, and I will try and keep my comments brief because you all know I have some passion here, and I know we're all working toward this goal. But I just want to say a couple of things just to kind of get on the record, hopefully for any folks who are watching too. I think it's really, my comments are going to be pretty much around the commitments and pre-petition screenings because that's a big deal right now. And I want to bring everybody back to page 1 of the materials, remind folks there's a definition there. I think sometimes we forget what this really means. But for us up here on the big picture, this is a big, huge deal because we're the people ultimately responsible to getting it to the court to say, we're going to take away somebody's rights. Somebody who hasn't committed a crime, going to jail, we're going to take away their rights. This is a big deal. It's one of the harshest things we do. On the other hand, let's go all the way to this end in this day and age, and I don't say buzzword, but the attention on public safety. Some of our friends on the bench are getting very hostile attention for allowing people out after their 72 hours or not. This is the important structure to make sure that's done right. This is the hours and thousands of hours of communications that happens. And our friends on the bench, they have a hard job too. They have a hard job. But the time is, this is what we're responsible for, is getting them the structure so we don't make those mistakes. We don't take away rights unnecessarily. We don't let somebody out who's going to go kill their mother the next day. That's huge. This is a big deal and is serious. So thank you for the presentation. I know you all know how serious this is, but because we have 1,000 things on our plate even today, I think sometimes we need a reminder, this is one of the biggest things we're involved in. So thank you, and thanks for letting me not ask a question, but just pontificate for a minute. And I just want to thank you and realize that this work is so important. I know this is hard, but I think what would be helpful for us is if we, and if I missed it, I'm sorry, if we could get a dollar cost, I know there's other costs, but a dollar cost for every person who goes through the pre-petition screening. It's a big deal, and I think that helps us when we make our decisions about investments in other places, because this is kind of the worst result. And I know the work that's been done by boards before us has been working not to be here, but I think that dollar amount, especially when we've seen a 42% increase over 3 years, is really important. And our duty as stewards of tax dollars to look at that. So I know it's a hard ask, but I'm going to ask that again, that we get a dollar for that. So we can make our decisions based on that, which we have to do. I'll stop there with the pre-petition screening stuff. You know, I'd like to talk about it more. I really would like to talk about it more, but I'm going to ask on the ERTs that, and it may be a year down the road, hopefully it's not quite a year. I'm glad, thank you for the data we got today. I'd really like to see that. I think we need more so we can evaluate that investment too. If we can really see how many days that facility was at capacity. And I mean capacity if it was fully staffed, because I know sometimes the last 2 years capacity was less because of staffing issues. And county and residents, I'd really like to see how much of that use is serving Scott residents. I know that's just a snapshot because we have plenty of residents still going to other places that are going things, but that would be a start. So I'll hold my comments there, but I do thank you for the work, and I realize how important it is and how back to that spectrum, you know, it's a really, really big deal. We don't want to take away rights when people don't commit crimes, but it's our duty to protect too. So thank you for doing the work.
Thank you for pointing out the rights dilemma. The rights of those not to be put away and pain versus the rights of those that have a right not to be able to live their life and property. It's a delicate balancing act. If we're happy for those of you who balance that every day. Thank you, Mr. Brecker, for your comments and for your passion and your insight. I'm willing to share that with the rest of us here too. So I'm going to go to Commissioner Ulrich now. Commissioner Ulrich.
Well, you did ask or mention when I was at the OMC school.
I wanted you to make your mic green first. So. There you go.
I was going to comment about this. I don't know that, for example, well, these numbers don't tell me if it's late users or they tell me people serve. You know, I guess I want to see that days. I don't use that term, but again, there's just not like that. What's the
Okay, calling Dr. Raddick to answer that. I see her based on the screen, and who can address that? Oh, Danielle.
The Earthing Crisis Facility it's new. We just celebrated their 1 year, so that's excellent. We do have a much more detailed data report to provide to those that are interested. That does include the bed days. It also includes outcomes. So how many people achieved what they set out to achieve on the plans? How many people felt like they were listened to? How many people felt like they got what they needed on certain use it again and provide it. That is under development. It was part of our contract that we worked out to provide that to us. The capacity question, I think we'll see more of as the year develop. This was the first year in operation. They were just getting started. They had a number of periods where staffing didn't limit types of beds that they could open and the number of them. I think we will happily share more information on that, but have more detail. The question that Commissioner Brecky asked around cost, I think that is a very important factor to what we are talking about here today, and just the general sustainability of our normal services ongoing. We know that costs can be because those outcomes are for individual people and they could take many, many different tracks. I don't know that we're going to be able to capture every dollar, but we do have a Scott County resident who has gone through the system, is interested in exploring his own personal journey, but then having sort of match that with costs. So we will at least have a case example that we can provide to the board.
That would be,
Yeah, on that topic.
yeah, go ahead.
The story also mentioned also described not only services, law enforcement, fitness, but also losing employment now for years.
Mhm.
How then we also think of the burden, right?
Mhm.
And that it will contribute to something. So it's an interesting story to share.
I'm looking forward to hearing that story. I think we all are. That it would be an amazing story to hear. Because it relates to the comment I'm going to make here at the end with a question. Any other comments, Commissioner Beer?
Well, I would only just say thank you. I mean, that's tough work. And you are in the trenches, so thank you for all that work. And this just feels like another one of those, going back to how we started with some of the definitions of shall and must, and it feels like another one of those logs to put on the pile to take up with the state to say, if there's those things that we have to do and there's a certain way that we have to do it,
Yes.
fund it. I'm trying to bite my tongue so other words don't come out.
Yeah. Because if it falls here, it falls on the property tax base on Matt Lehman's mother over on 4th Avenue. And that's tough. It really is tough. There's got to be another way to do that. So sorry, Matt, to pick on you, but that's just the way it is. Other comments or anything? If not,
I would just say, Mr. Chair,
Sure.
it is to piggyback on what Commissioner Beer said. The timing of all this, what Luke said, somebody comes and evaluates, it's like 24 hours a day, a lot of times while we're sleeping, people are doing this stuff. And so it's almost thankless, but thank you.
Yes. In the opening information that we shared, and I think with Barb Dahl, when you gave us kind of the historical overview of institutions from about the time that state was founded up until the 1980s, when I remember when the institutions were emptied and the raging debate on whether this was actually a humane thing to do. And just, oh, by the way, you can look at blue tarps under a bridge along the highway and still ask the same question, was that actually a humane thing to do? But it was done, here we are. But the data that you shared, I believe, was that out of 100% of the people who went into an institution back in the 1800s, only 30% were cycled out a year later. So I was carrying that thought thinking, okay, did somebody have a crisis in their life? A child died, something traumatic happened. And a year later, they've kind of recovered enough to go back home. 70% of the people did not. They remained institutionalized. I just remember the 70-30 number. Now I'm looking forward to all the people that are going into the system today and how many are we're talking about committing. And correlating those numbers, it seems to be in the same range, 70-30, only the other way around. And I'm wondering if we have an expectation after the deinstitutionalization that given enough money, drugs, and intervention by skilled people, that people can actually be cured. And maybe cure is the word we're all choking on here, because if I get shingles, I know I'm going to do something for 30 days and be really miserable, and you don't want to be around me, but I'm going to be healed. At some point, I'm going to be better. You get the mumps. At some point, you're going to be better. But is there such a definition that fits this? Does somebody actually get better, or do we manage it? It might be a rhetorical question, but know that that's kind of how at least this commissioner is processing what you're asking us for. And it may be we just have to come to terms with the fact that some people aren't going to get better, and we still have to weigh their rights versus the neighbor's right not to have garbage burned in his porch or something, like whatever the behavior is. Again, I'm not really asking for an answer right now, but I want you to know we think about these things, and I know you do too. And if you can think of a way to help illuminate the problem we're being asked to consider here, we're all ears. We'd like to hear it, because I think our hearts are in the right place, but sometimes our lived experience and our knowledge of the situation are maybe askew. Help us bring it back into skew. And Mr. Brecky, thank you for living in this world and being able to share some of that skew with us, some of the reality of what you're dealing with. Chris, you have any closing comments, or colleagues, anything else before we thank you for your service? Thank you for the presentation and move on the agenda.
No, thank you very much. My apologies to the people that are remote
Yeah.
because of our technology issues. We thank you for your work on this. That will conclude.
Thank you. We are, into the technology point, we are going to continue the hybrid model for a couple of months yet. We will get this worked out so that if you're sitting at home or remotely on Zoom, you will be able to participate and hear just as good as if you're right here in this room. So thank you for that.
Dr.